Good afternoon, everybody. It's my pleasure to welcome you to the next session on chronic pancreatitis, which I'm sharing together with Igor Stripnik. I would like to leave over, because some of the other chairmen couldn't make it, the chairmanship to Asbjørn Drews, who will do this, and I will be a little bit in the background because I already talked that much in the morning and just have finished another 1.5 hour sessions, and I have to keep my voice for the General Assembly and another talk tomorrow. So we have, I think, a series of very nice invited and also presentations from the abstracts, and it is my real pleasure to call upon the previous IAP President Minoti Apti, who is joining us from down under on understanding pancreatic fibrogenesis implications for disease progression and treatment. Please, Minoti.
Good day, everyone. I'd like to thank the organizers for the opportunity to discuss with you some updates in our understanding of pancreatic fibrogenesis and how they pertain to our understanding of disease progression and treatment opportunities. I do not need to tell this audience that pancreatic fibrosis is a major histological feature of two prominent diseases of the pancreas, chronic pancreatitis and pancreatic cancer. Here you can see an H&E of advanced chronic pancreatitis showing abundant scarring of fibrous tissue surrounding remnants of acinar cells. Similarly, in pancreatic cancer, you can see islands of tumor cells that are surrounded by abundant collagenous stroma. We were the first in the world to isolate and characterize the cells that make the fibrosis in pancreas, and it is now very well established that these cells play a major role in pancreatic fibrosis. So here you can see a picture of desmin-stained acinar cells. These are desmin being a stellate cell selective marker and a cytoskeletal protein. And you can see desmin-positive stellate cells around the basolateral aspects of acinar cells. When cultured, this is what they look like. They have prominent lipid droplets surrounding a central nucleus, and these lipid droplets contain vitamin A. It is the ability to store vitamin A that differentiates pancreatic stellate cells from fibroblasts. More recently, these cells have also been found around the endocrine component of the pancreas, or the pancreatic islets. And here is a picture of GFAP stained PSCs, GFAP being another selective marker for stellate cells called glial fibrillary acidic protein. We've also found activated stellate cells around islets in pancreatic disease. The islet PSCs are slightly different from the exocrine PSCs in that they seem to have fewer lipid droplets, and their capacity to respond to activating factors is slightly different from the exocrine stellate cells. Nonetheless, stellate cells play a major role in maintaining extracellular matrix turnover in health, and they have a number of other functions that have been recently identified, which I don't have time to go into. During pancreatic disease, these cells become activated to a myofibroblast-like phenotype, which is associated with the loss of vitamin A stores and a number of functional changes, including excessive synthesis of extracellular matrix proteins. Many activating factors have now been identified for activating stellate cells over the years, and a number of signaling pathways have also been characterized and defined, which mediate this activation process. But in recent times, there has been more interest in the pathways that might mediate the reversion of activation to quiescence of these cells. And these pathways include the PPAR gamma agonists, such as stroglitazone, all-trans-retinoic acid, which is a metabolite of vitamin A or retinol, and the vitamin D receptor ligands. Now, chronic pancreatitis is associated mainly with alcohol abuse. Many groups around the world have shown that alcohol can cause injury to the pancreas because acinar cells can metabolize alcohol, and ethanol predisposes the acinar cells to premature intracellular activation of digestive enzymes. It also perturbs homeostatic mechanisms, including the unfolded protein response leading to ER stress and autophagy. We've also shown that alcohol can be metabolized by stellate cells to its toxic metabolite acetaldehyde and its byproduct oxidant stress, both of which can activate stellate cells. But these cells can also be activated by cytokines that are released by the nearby injured acinar cells. Everyone knows that alcohol abuse is often associated with another lifestyle factor, that is smoking. And interest in the effects of smoking on stellate cells has also increased in recent years. We know that aryl hydrocarbon receptor ligands in cigarette smoke can activate leukocytes, including CD4 plus T cells, to secrete interleukin 22. And this is of interest because interleukin 22 can act on stellate cells via its receptor on stellate cells to cause stellate cell activation. So in the milieu of alcohol and smoking, these are various different pathways that could lead to pancreatic fibrosis. To see if this happens in vivo, we developed a model of alcohol feeding in rats, where the rats were fed alcohol in a chronic fashion, but also they were challenged with LPS. And the reason we use LPS or endotoxin was because we know that alcohol increases gut permeability and increases serum endotoxin levels. Certainly, alcohol and LPS together causes increased pancreatic injury. But on top of that, if we expose these animals to smoke, you get a significantly higher injury scores, as well as significantly higher fibrosis scores. The fact that there is more fibrosis after smoking indicates that the stellate cells must be responding to compounds in the smoke. And one of the ways that it might do that is via the nicotinic acetylcholine receptors, which recognize toxic compounds such as nicotine and NNK. We found that both rat and human stellate cells express a number of isoforms of the nicotinic acetylcholine receptors, which with the alpha-7 isoform being a predominant one, which was induced when the stellate cells were exposed to ethanol and cigarette smoke extract. Interestingly, if we inhibited the receptors using a mecamolamine, we found that the activation of stellate cells in response to alcohol and cigarette smoke extract could be significantly inhibited, indicating that this pathway may be a mechanism by which fibrosis can occur upon exposure to smoking. In collaboration with Anna Gukovskaya's group, we also found that the alcohol LPS animals exposed to smoke showed significantly higher macrophage infiltration compared to the other groups. And this is pertinent because it might explain the perpetuation of stellate cell activation. So we know that the effects of alcohol and smoking and inflammatory mediators activate stellate cells. Once activated, these cells secrete their own cytokines to cause an autocrine effect, which can perpetuate their activation. But stellate cells also secrete interleukins 4 and 13, which recruit macrophages into its M2 phenotype. And this is important because M2 macrophages are profibrogenic. They secrete growth factors that can in themselves activate stellate cells again. And they also secrete tissue inhibitors of metalloproteinases, which prevent deposited collagen from being degraded and therefore potentiate the amount of fibrosis that is deposited. In terms of the diabetes of chronic pancreatitis, the role of stellate cells around islet cells might be of importance because we know that stellate cells are present and activated around islet cells. And a Japanese group has shown that the beta cells, if incubated with stellate cells, show a decrease in function in terms of insulin secretion, and they also show increased apoptosis. In our lab, we've recently shown that stellate cell exosomes exosomes derived from stellate cells are very readily taken up by mouse beta cells. And while the insulin content of the beta cells is unchanged, there's significant decrease in insulin secretion by the beta cells exposed to stellate cell exosomes. We are now in the process of identifying the cargo of these exosomes to work out which factor mediates this effect. But it's interesting because this might explain a role for stellate cells in the diabetes of chronic pancreatitis. So over the years, many groups have been working on looking at inhibition of stellate cell activation by inhibiting a number of the factors that mediate stellate cell activation. I just wanted to touch upon a couple that have translatable potential. So recently, there's been a trial on the vitamin D receptor ligand that's been looked at for the progression of recurrent acute pancreatitis to chronic pancreatitis. We have been recently funded by Department of Defense grant in collaboration with groups in the US to look at the interactions between stellate cells and macrophages, interrupting them by using interleukin blocking peptides and also nicotinic acetylcholine receptor antagonists. Before I go, I just wanted to touch upon very briefly on pancreatic cancer, because we know that activated stellate cells produce the collagenous stroma of pancreatic cancer. And of course, chronic pancreatitis is a major risk factor for pancreatic cancer. Pancreatic stellate cells have been found around the earliest lesions of pancreatic cancer called pannins. And many groups have now shown that stellate cells interact very closely with cancer cells, as well as with other elements in the stroma, including immune cells, endothelial cells, neuronal cells, and extracellular matrix itself. And all these interactions potentiate cancer progression. So in the pancreatic cancer field, it is now widely acknowledged that it is no longer enough to just target cancer cells, but that the stromal tumor interactions need to be targeted as well. And in this regard, many preclinical studies are available to show that inhibiting stellate cell cancer cell interactions along with a chemotherapeutic agent can improve cancer outcomes, at least in preclinical models. Some of these have been transported into clinical trials. So there is trials underway with vitamin D receptor ligand, minalide, ATRA, and hedgehog inhibitors. And these trials are either underway or completed, and we do await their results with interest. So all in all, pancreatic stellate cells play a major role in pancreatitis as well as pancreatic cancer via many pathways that are increasingly characterized. And this might suggest to us that specifically targeting certain pathways may be a beneficial exercise to develop novel therapeutic approaches in these diseases. With that, I would like to acknowledge the members of our group, as well as the collaborations we have both within Australia and internationally, and our funding bodies. Thank you very much.
Yes, thank you. This was a very interesting report. And next report, Esbjørn Mol Dreves, pancreatic pain treatment options, please.
I'm going to address management of pain in chronic pancreatitis. First of all, you should be aware that the management is really multimodal, and there are many treatment possibilities. And of course, in 12 minutes, I have to do a selection of what I can address. Luckily, the forthcoming speakers will speak about the invasive procedures, the endoscopy and the surgery, so I need not use my time for that. I will focus today on analgesic management, which is the mainstay of pain treatment in chronic pancreatitis. The rest you have to read, for example, in the references I have cited down below. Before I move into management, I shortly want to speak about the pathogenesis, because otherwise it can be difficult to understand the rationale for what we do. Unfortunately, many pancreatologists believe that the reason for pain in chronic pancreatitis is either obstruction or tissue hypertension, but likely peripheral factor doesn't mean much, except for the neuropathy that we see in many patients due to the destructions of the nerves, in the same way as you see it, for example, in phantom pain after limb amputation. This neuropathy results in an increased firing from the afferent nerves to the spinal cord unit, where they will also over time develop a sensitization, so the nerves fire spontaneously or at a lower threshold. This sensitization can spread to the upper centers in the brain and in the central nervous system, together with a lack of the normal inhibition that we have on the afferent input. So in conclusion, the low threshold or spontaneous neural firing gives, together with pain, changes in pain networks and lack of normal control system, a central system where pain becomes more or less independent of the original drive. So this slide just shows the same, that more or less what you see when you investigate these patients is central findings rather than findings related to the periphery. And that brings me to the management with analgesics, because most analgesics, they exert their effect on these central sensitization, so they function in the brain and central nervous system rather than in the periphery, although a few of those also have peripheral effects. Now, the question is then, are these analgesics really effective? Because all of you know patients that respond really badly to treatment. But this is not because the analgesics are not effective, because the answer to that question is yes. If you look into the number needed to treat for the different analgesics, the number needed to treat is about 1 to 2, especially if you use them in combination. The problem is not the effect, this is the side effects, because you can have a very good effect of a certain drug, but because of dryness of the mouth accommodation problems, severe constipation and so on, patients do not tolerate the treatment, and this is the key problem. Especially it is a problem for the gut, because all analgesics more or less have severe effects on the gut that is already suffering due to the gastrointestinal disease we see in chronic pancreatitis. If you want to read more about that, we published a recent paper which we called How to Deal with the Catch-22 Situation. So now moving back to basic, what do we have in our armamentarium? Well, we have a lot of studies that has been done in chronic pancreatitis. Some of them are also rather good RCTs, but in reality it's mainly done with a few adjuvant analgesics and opioids. And you could of course say, well, if this is what we have studied in chronic pancreatitis, should that then be our recommendation? And of course it is not, because there are much more analgesics out there. And even though they have not been used or tested, in chronic pancreatitis, they are still effective. We know that from a clinical point of view. And in the ideal world, of course, you should do good randomized controlled trials for all different kinds of analgesics. And now let's say that we really have done that, and I can then ask you another question. Would we then be happy? And of course, the answer is no, because there are also many different kinds of chronic pancreatitis. They could have different degrees of fibrosis, neuropathy, calcifications. Some have pseudocyst, some have bacterial overgrowth, and they should all be tested with the different medications. And combinations of analgesics should be tested on all these different conditions. So that will never happen, because there is an endless number of combinations. But the good thing I'll tell you today is that the difference between individuals, for example here with chronic pancreatitis, is bigger than when it comes to two different diseases. So what I'm telling you here is that you can use the knowledge you have, for example, from patients with low back pain in patients with chronic pancreatitis, at least more or less. Because what means something when the disease has become chronic is more like the duration of the pain, the degree of central sensitization, the psychiatric comorbidity, the co-medication, social factors, and so on. In other words, when chronification is present, pain is pain. So you can use universal recommendation for analgesics, such as we published here, for example, for pancreas cancer pain. Normally we step up or step down that is, we start with the weakest analgesics and move up to the stronger analgesics, but we can also in some conditions start with the strong analgesics and taper down to the weaker ones. But again, be aware of the side effects. This is what actually stops treatment normally. I cannot use time to go through all the different analgesics. Just want to recommend you to read, for example, the guidelines we published in 2017, where there is also a flow chart on what we recommend to use in the different indications. Before I stop, I just want to give you a few warnings. The first of them is that you should be aware that even though you can use universal recommendations, it always have to be individual, because some patients respond to some analgesics but not to others. Some have side effects to some analgesics but not to others. So you need to have a big armamentarium of different drugs that you can use on the individual basis. My second warning is that you should be aware that pain is different between patients. Some have continuous pain, some have intermittent pain, or both of them together, and they have to be treated differently when it comes to analgesics. The problem is just that the pain is not the same over time. And this is from the Dutch pancreatic group, showing that, for example, continuous pain in this Sankey diagram can move down to be intermittent pain on year 2 or vice versa. So you have to evaluate your patients regularly. And the third warning I want to give you is that you should be aware that this is really complex. As I showed in one of my first slides, management is multimodal, and what happens is very often that the pancreatologist do not believe that he or she can manage such complicated patients and leave it to the pain clinic, for example. The problem is that there are many reasons for pain in chronic pancreatitis. Some of them are related to the pancreas, others are not. And for example, if patients develop a peptic ulcer, surgical complications, drug-induced bowel dysfunction, diabetic neuropathy, ischemia of the gut, and so on, that can never be found by the pain clinic. It's only you as treating physicians that can manage all these different complexities that we see in chronic pancreatitis. So even though you may refer the patients to the GP, to the junior doctor, or to the pain clinic, you should be the one in charge and keep the responsibility. And that's all from my side. Thank you very much.
Thank you for a very interesting report, dear Esbjørn. And the next report, surgery is always superior to endoscopy in chronic pancreatitis. Guralp Seheb and Lasio Sako, please.
So it's a great honor for me to be a part of this wonderful congress organized by Natalia and her team. Unfortunately, not present in Kiev, but I hope that times will change so that we will meet all in Kiev again. Today, I would like to talk about whether surgery is really superior about endoscopy in chronic pancreatitis, or what is the evidence which we know so far. Just to remember, with chronic pancreatitis, we have a certain amount of symptoms and morphological changes which lead to the main cardinal symptom of pain. And this is described by obstruction of the ductal structures, of the biliary structures, necrosis, fibrosis, inflammation. This all can happen once in one patient, but can also that certain features of these morphological changes do have a majority in these patients. But however, what they all have is that also they have some kind of an interpancreatic neuropathy, which clear neural damages, which I would like to underline here, because this is very, very important when regarding the indication of surgery in chronic pancreatitis. When you look on this slide, just to remember, maybe you saw that a couple of times, in normal pancreas on the left-hand side here, you can see only some small nerves, which we know in chronic pancreatitis, these kind of nerves are completely enlarged. And also we have the same situation, pancreatic cancer, with additionally neural invasion of cancer cells. When you regard these features in chronic pancreatitis, it's absolutely independent whether these nerves are altered, whether the patient has got alcoholic, idiopathic, or tropic chronic pancreatitis. It's clear, striking different from normal pancreas. And even if you go in hereditary pancreatitis, you can see this typical feature of neural hypertrophy and neural density in these patients. So we have a clear, independent situation of these neuropathic features regarding etiology. The additional what we have, another part of neuroplasticity in chronic pancreatitis, is that we have a targeted immune cell infiltration of these enlarged nerves by immune cell infiltrates, which we call the pancreatic associated neuritis, with both together are clearly associated with pancreatic neuropathic pain sensation in our patients. Now, when you just have a close look on these patients with the immune cell infiltrates and look whether they have no pain or pain, then we can see that there's a particular of immune cells which are upregulated in these patients, and these are the mast cells. So that we somehow have identification of the mast cells which induce this nociceptive hypersensitivity in pancreatic neuritis. And why we do this? Because we can also check this in an experimental setting with mast cell inhibitors and stabilizers like ketotifen and chromoglucate, where when you use them, you can markedly reduce the pain sensation in our small patients in a mice model with chronic pancreatitis. So this means that in chronic pancreatitis, we have a situation which is neurotrophic with large intrapancreatic nerves, with leading to neuroplasticity and with this to neuropathic pain. And that also we have some kind of a neuroimmune crosstalks which then enhance this intrapancreatic neuropathy and further augment neuropathic pain. So we have a burning site at chronic pancreatitis locally, but what's about central neuroplasticity? I mean, Professor Drevis just talked before me, and I think I would like to show one of his great data that we do have clearly central changes in patients with chronic pancreatitis, with different EEG PANS, with reorganization or in the chronic pancreatitis in the adaptive cortical system. And further on, we have altered brain microstructure. These are all the news which we have known so far, and much more coming from Professor Drevis' group. But this all, which is very important, is that we have long-term painful disease, and long-term is very important, leads to these irreversible chronic central reorganization and function and damage, and which then lead to these hard to treat neuropathic pain sensations in these patients. So keep please this in mind. Now we have a situation like this one, like a fire in the pancreatic head, which then leads to changes in the nerves with increased neural density, pancreatic neuritis, neural hypertrophy, the central reorganization, and central changes in especially also adaptive pain sensation. And then what this lead is that we have a complex situation, complex pathological changes in the peripheral and central nervous system, which are leading to pain in this disease. So when you just ask me whether we can only solve this problem with a stent, with such a thing, we would talk about this now. So what does the evidence say? When we have got our nice multidisciplinary guideline 2017 published in the UEG journal, there we could clearly see that there was an agreement that surgery is clearly superior to endoscopy with the data we have so far. And that even, and most importantly, early surgery is favored over surgery at a more advanced stage. So, but this is still not the reality. Look, like this patient is a 44-year-old, so quite young patient, had a long-term alcohol abuse, was diagnosed first with pancreatitis 2001, long-term alcohol abuse, several stents, 7 occlusions, portal vein thrombosis, metal plants, plastic stent, and so on and so on. And suddenly, after a long story, now currently has got pyloric stenosis, and then sees for the first time the surgeon. But the problem is that at this situation, we have got a situation with portal vein obstruction, huge, massive collaterals, and in a situation where, at least in this way, we even could not do a resection of the inflammatory tumor. And so we did only a oncological double bypass in a patient which has actually no oncological disease. So this is actually sad, and we want to avoid this. And we have got evidence. And one of the first evidences we have was of Professor Dietes and published in Endoscopy, and also Professor Kahn in New England Journal of Medicine. I think I don't have to introduce so much that even here you see the low number of the patients, but this is the view that the interim analysis showed in favor for the surgery, where it was then stopped much earlier, with lower SPPK pain situation, better health situation, and also less interventions. When we saw these patients, then after even 5 years, still they had lower SPPK pain. 80% of them had partial pain reduction still in the surgery group. And of course, and I think this is very important, less re-intervention, 5 versus 70% in the surgical group. And what was very interesting is nearly half of the endoscopy patients at the end required operation. This means that surgery is clearly more efficient than endoscopy in this situation. Now, when we just look on the situation when we should do the surgery, because this is actually the most important part, is that when you do an operation after the patient has a longer pain-free situation, or opioid use or not, does matter. This means when a patient suffers longer, or if he needs opioids to get rid of the pain, then actually we are already too late. And here it clearly indicates that early surgery leads to less pain and opioid use. Similar data we have from a cohort study by Ali and al., where reported that patients who reported duration of pain less than 3 years, no preoperative opioid use, and endoscopic treatments less than 5 procedures had the best outcome. So that means, again, the timing of surgery is crucial. And for that, our good Dutch colleagues, again, in a wonderful setting, established the ESCAPE trial, and I think you know them all. They wanted to evaluate this to see the risk and the cost, and of course also the outcome regarding pain of early surgical intervention in a current step-up approach. The first step is always the optical medical treatment with our patient. The second one is when it fails to do an endoscopic intervention, and when this fails, then to go on for surgery. Now, when you see then the patients which were included, then you can see that 95% failed after the first step. Then endoscopic treatment was then applied over 40 in a success, and 60% who were failure, and then these went for surgical treatment. And when you can see then again, the early surgery group versus the only step-up approach group had, again, when you do an early surgery, long-term pain-free situation. Other parameters did not matter much between these two groups, either than the number of interventions. It's clear when you go for early surgery, then you do actually better with the number of interventions. So again, here, early surgery provides better outcome, long-term pain control with less re-interventions in a step-up approach where you can identify the patients at high risk and go for surgery. Now, when you look at this, remember when you got all these, also the nerve situation and all the central and local changes, then it's clear what is more important, an early timing single operation or up to 10 times standing. I think the question should be clear because pre-randomized controlled trials proved it. So yes, I think it is superior to surgery, but we have to act as a team in simpler centers and hand in hand, because we have to avoid this. And this is a 28-year-old patient which I have operated here in Turkey. And the initial diagnosis was 2015 with an alcoholic chronic pancreatitis, repetitive ERCPs, and 2 unfortunately broken intrapancreatic stents. And as you can see, here's the first stent in the head, and then at the tail, there's another stent which has been broken after repetitive injection. Here's the operative situation where we, in the first try, we do some kind of a burn or a Vega approach, and then after extravasation of the pancreatic head, then you can see the first stent. Here is the first broken stent. You open it longer and modify it to a fry procedure, and it did not last, so we have to do it even more, because then here, what you can see here is the second broken stent, and we took out also this one and then did a long pancreatical jejunostomy, so some kind of a modified fry procedure, and then with this indicated the drainage of the patient. So conclude my talk, I think hand-in-hand step-up approach is the key. This means we have to go on together with the gastroenterologist and surgeon and talk about all the patients. And because it is very important that it should not come out from this discussion that not every patient needs surgery. But when the time for that is come, then we have to go for surgery, because we know long-term results are better. And I think it is very, very, very important that we don't have to wait when endoscopic treatment fails. It can happen. This is not a big deal, but then we must see a patient, because when you do fear from problems for your patients to send them for the surgery, then you always forget that when you wait longer to consult your surgeon, then clearly the major, maybe also perioperative complications can arise. So for that reason, please, let's work together. I want to thank you for my talk and would like to welcome you in Istanbul for the European Pancreatic Club meeting in 2026. Thanks.
Dear chairs, dear ladies and gentlemen, I have nothing to declare. I wish to talk about MPD stones, MPD strictures, biliary obstruction, and the therapy of pseudocyst in chronic pancreatitis. Several randomized clinical trials and meta-analyses have compared endoscopic versus surgical therapy in cases with chronic obstructive pancreatitis. Overall, these studies concluded that surgery is superior to endotherapy with regard to chronic long-term pain relief. I'm sure that these have already mentioned in the previous talk. The recent European guidelines state is that surgery is superior to endoscopic therapy in pain relief. However, it still recommends endoscopic therapy as the first-line treatment after failed medical therapy following discussion by the multidisciplinary team. The clinical response should be evaluated at 6 to 8 weeks. If it appears unsatisfactory, the patient case should be discussed again and surgical options should be considered. What can an endoscopy do in chronic pancreatitis? Extracorporeal shock wave lithotripsy is the gold standard for non-surgical MPD stone removal. ASVL should target radiopaque stone with a minimal diameter of 5 mm. Clearance of the MPD stones are more frequently obtained in the case of single stones and stones confined to the head and body of the pancreas. A meta-analysis showed that ASVL resulted in complete ductal clearance in 70% of patients and resulting in absence of pain in 64% of patients at 5-year follow-up. Adverse events are uncommon. The most frequent one is the post-procedural pancreatitis. The addition of ERCP to ESVL provided no additional benefit. Peroral pancreatoscopy guided lithotripsy is an emerging technology that can be performed during ERCP. It permits stone fragmentation under direct visualization, and ductal clearance can be confirmed after lithotripsy. In this meta-analysis, ductal clearance was achieved 62% of patients. Clinical success at 30 months of follow-up was noted in 89% of patients by improvement in pain, decreased narcotic use, or reduced hospitalization. Mild adverse events occurred in 14% of the patients. Painful dominant MPD structures located in the head of the pancreas can be treated by a single 10 French plastic stents. In response, the endotherapy should be continuous for at least 1 year before removing the stent. During this period, the stent can be replaced routinely or on demand based on symptoms or signs of stent dysfunctions. Long-term pain relief was reported in 67% of the patients. Refractory PD stricture can be treated with multiple side-by-side plastic stents or fully covered self-expandable metal stents, placement, or surgery. In this meta-analysis, the outcome of multiple plastic stent and fully covered self-expandable metal stents were compared in patients with refractory pancreatic duct stricture. Improvement in pain after stenting, recurrence of pain and stricture after stent removal, and endoscopic reintervention rate were comparable between MPS and SAMS. However, SAMS was associated with overall higher risk of adverse events such as stent migration, CBD obstruction, and new MPD stricture formation. Biliary stricture complicate frequently of chronic pancreatitis. No randomized controlled trial comparing endoscopic versus surgical therapy was found. Biliary stricture due to chronic pancreatitis are especially resistant to endotherapy due to periductal fibrosis and calcification, and therefore treatment with a single plastic stent has been abandoned for this indication. Stenting should be done with multiple simultaneous plastic stents, and it can provide long-term success in 90% of the cases. It's important selecting patients deemed to comply with repeat ERCPs and who are at high surgical risk, present with portal hypertension or have local abdominal condition contraindicating surgery. Patient compliance with stent exchange may be poor, giving to rise to potential fatal complications, and therefore a registry and the recall system for stent exchange should be established to avoid these septic complications. A multicenter international randomized trial was performed comparing 2-year efficacy and safety outcomes of multiple plastic stent and fully covered self-expanded metal stent to treat biliary stricture in patients with chronic pancreatitis. Stents were placed for 12 months in both groups. Multiple plastic stent and SAMS have had similar rates of structure resolution and similar rates of serious adverse events. However, plastic stents required a higher number of ERCP procedure, and a higher number of stents were placed over 2 years compared with SAMS. Based on these results, covered SAMS have been proposed as an alternative to multiple plastic stents with the advantage of reducing the number of ERCPs needed. Approximately 20 to 40% of chronic pancreatitis patients develop pseudocysts during their disease. The questions are in whom to treat, when to treat, and how to treat. Within the first 6 weeks after an acute bout of pancreatitis, 40% of pseudocysts resolve spontaneously. However, spontaneous remission after 12 weeks is very rare, and complications are observed in up to 2/3 of cases. An increase in pseudocyst size over 5 centimeters is associated with the development of complication. Universally accepted indication for pseudocyst treatment include the presence of symptoms such as pain, complications like bleeding or infections or compression of the surrounding organs. Treatment of asymptomatic and uncomplicated pseudocysts is not indicated regardless of size. About the timing. If a recent episode of acute pancreatitis has been identified, or if the pseudocyst was not detected on prior examination, the pseudocyst should be observed for up to 6 weeks to allow for either spontaneous resolution or maturation of the cyst wall. Otherwise, prompt drainage can be performed. Unlike acute pancreatitis-related fluid collections, ductal communication with the pseudocyst is evident in a higher proportion of patients with chronic pancreatitis. Therefore, MRI with secretin-enhanced MRCP should be performed to diagnose MPD rupture before drainage of the pseudocyst. In the absence of MPD rupture, endoscopic drainage can be only transmural. If a partial MPD rupture is present, insert of a stent bridging the rupture can be a treatment of choice. In the case of a complete MPD rupture, that is the disconnected pancreatic duct syndrome, when we remove the transmural stent, there is a high risk of recurrence of pseudocyst. So therefore, a long-term stenting should be considered in these cases. How to treat? In this randomized controlled trial, patients with pancreatic pseudocyst underwent endoscopy or surgical cystogastrectomy. There were no difference in treatment success, complications, or interventions between the groups. None of the patients who received endoscopic therapy had a pseudocyst recurrence compared with one patient treated surgically. The length of hospital stay was shorter, and the total mean cost was lower for patients treated by endoscopy. These results were confirmed later by several meta-analyses. In the recent guideline, therefore, endoscopic drainage is recommended for the treatment of pseudocysts that are within endoscopic reach. Endoscopic drainage can be performed transpapillary or transmurally. Transpapillary drainage is feasible only for small pseudocysts communicating with the MPD in the head or the body of the pancreas. Endoscopic transmural drainage should be performed under echoendoscopic guidance because it has a higher technical success rate versus conventional approach due to the presence of non-verging collections. If extrahepatic portal hypertension is present, US-guided puncture has been recommended to decrease the risk of bleeding. Double pictoplastic stent should be inserted to drain the pseudocyst into the digestive lumen until cyst resolution, but with a minimum of 2 months of stenting. This is the endoscopic procedure, the pseudocyst puncture under US guidance, the dilation of the fistulous tract, and the placement of 2 double pictoplastic stents into the pseudocyst. To sum up my talk, MPD stone can be successfully treated either by RCP or ESVL and pancreatoscopy, depending on the size of the stone. In the cases of MPD strictures, early surgery should be considered in cases unsuitable for endoscopic treatment and those with a suboptimal response to endotherapy. Endotherapy should be offered as a minimally invasive initial treatment in cases with positive predictors for good long-term outcome. Biliary strictures can be well managed with multiple plastic stents or SAMs. And the recommended treatment for chronic pancreatitis-related pseudocyst is the endoscopic drainage. I believe that the decision of between endotherapy versus surgery should be individualized by a multidisciplinary team. Thank you for your attention.
Yeah, thank you for report, and we have one question to Guraup Seichen. One question to Guraup Seichen. Even in the latest randomized trial, approximately 30 to 40% did not respond to early surgery. How can this patient be identified?
I think this is a very good question, Georg. I think the most important thing is, first one, who can profit from this. And I think they can be found very easily. And these are the guys who maybe had a prior response to endoscopic treatment, but then failed after this was somehow only a short-term pain relief or symptom relief. And then I think these are clearly the patients you have to go for surgery. regarding your question, the one of the failures, and I think what I really underlined is that I told from the beginning that not surgery must be the main treatment option for all chronic pancreatitis patients. And I think here you have to really go hand in hand. And we have to somehow, when we do that really properly, like tumor boards, to do chronic pancreatitis boards, we will identify after going together hand in hand who really will benefit from this. When you ask me this, I can honestly not tell you which patients do really will not benefit from surgery. But the one we do characterize who can benefit, and I think they should be then very happy that we got this in a hand-in-hand approach. And I think here we have to gain more experience together.
I don't know, can anybody hear me?
No. Yes, speak up.
Yes.
Okay, very good. Well, as Skyrab know, I disagree very much with him because what I believe is that in most patients this problem is actually central sensitization, and that also reflects a question by Apte in the chat. The problem is that when you have chronification, typically reflected in long-lasting, continuous pain, it's very difficult to treat with anything, and that is not only surgery, endoscopy, that is also medical treatment. So where I agree with Gyalp is that we should have a multidisciplinary approach, because some patients should be treated in one way and others in another way. The problem is that the whole biological rationale for treating with endoscopy and surgery is wrong. Because if you have a patient with neuropathy or lesions of the nerves, I mean, you can never cure them just by cutting the nerves at a higher level. It has been shown for the last decades that this is, the last centuries, that this is the wrong approach, even though surgeons have tried to do that for many years. I mean, it gives a short-lasting relief, but in the long term, there are no differences. And that is actually also reflected in published studies, because, I mean, in reality, there are really no differences. And we cannot, in a recent study we have done, which is not yet published, there are simply no differences between surgery and endoscopy, likely because the approach is wrong in many of those patients. So what we have to do is really to look into the patient's symptoms, try to characterize how the pain system works, and then in selected patients, refer them also to endoscopy and surgery if it's not too late. I hope you can agree with me on these points.
I definitely disagree. I love you, my friend, but on this matter we are somehow a little bit different, because I know you. It's not that you are completely wrong, but it is clear that we really do benefit, and I think you have got this firing, and this, I don't call it for nothing, fire. And when you have got the nerve stimulation and you have got the neural problem and within the pancreas, and when you can get rid of the cause of this, then this firing gets reduced. And with this, the patient get better really when you do in a radical way. And this is always also the case when you do pancreatic surgery. In pancreatic cancer, when you do pancreatic cancer radical resection, then you will have good results. When you do a good radical resection in chronic pancreatitis, then this will also be the case. So for that reason, we see the patients also in randomized controlled trials and in my life that they really do better and long term. For that reason, to call this clearly not correct is a little bit harsh, my friend.
I love to be provocative, you know that. Likely we have to find a balance somehow. And I also like your approach, Gyalp, with the multimodal and multidisciplinary approach, because we really have to be more serious. I mean, I'm not only speaking about with the surgery, we have to select the right patients, or endoscopy. It also goes for the medical treatment. It can go even wrong. They can get into, I mean, opioid dependent, and all this shit can happen. So we really have to take this problem seriously, because pain is the utmost problem in chronic pancreatitis.
Next question: how long does it take for central for central, how long does it take for central reorganization to occur? When does the transition from pain of acute pancreatitis change to chronic pancreatitis?
If I may answer, we have some good animal data because we cannot really investigate this in humans, that has shown that with increasing bombardment of the afferent neurons to the central nervous system, you will develop a central sensitization that is really long-lasting within the first 2 weeks. So that's also therefore the bridge to from acute to chronic is can really be difficult. But then again, it depends on a variety of factors. It depends on the intensity of the peripheral bombardment. It depends on genetic and epigenetic factors in the individual patient. It depends on the co-medication, the age, and many things. So this is not something you can just easily answer. But typically, when the pain has lasted several months, we normally call it chronic. And in that case, it is very often irreversible if you look into other pain diseases and chronic pancreatitis.
Thank you.
Let's go on.
Yeah, the next report, George Bayer, staging of chronic pancreatitis. Are we any closer? Please.
Well, hello, everyone. Thank you for giving me the opportunity to talk at this European Pancreatic Club, which unfortunately, again, we'll have to meet in the virtual space. I was given the quite difficult task to talk about staging chronic pancreatitis and to give an answer on the question, which is quite suggestive of whether we are any closer or not. Actually, to answer that question, you have to first agree on where you want to be and how close you want to be to what. And as I will show you, it's not actually that easy. And I still think we have quite some work to do. There are no conflicts of interest, which I have to declare that are relevant to the current talk. Now, the first question which needs answering is obviously, what is disease staging and what is it good for? Disease stagings are actually classification systems that use diagnostic findings of any kind to produce clusters of patients, mostly on etiology, pathophysiology, and severity of disease. And those clustering can then be used to do a number of things with it. For example, you time the hospitalization of a patient. You can use it to analyze your case mix classification or the utilization of resources and reimbursement in your healthcare setting. You can use it for quality of care assessment. It could be used for clinical trials. It can be used to allocate staffing and facility planning in healthcare institutions and therefore improve care and efficiency. It could be used for specialty board certification and allocation of certain clinical privileges. And of course, it's quite useful in medical education to help students and residents to understand how diseases work. Now, the easiest way of coming up with the staging classification is something like that. So there are multiple stages, and it always starts with an uncomplicated stage where a disease that has been diagnosed has no complications. And then oftentimes there's an intermediate stage where there may be local complications or manageable complications or compensated complications. And then oftentimes there's a later stage where it's decompensated or complications involve multiple sites or systemic problems and so on and so on. And maybe there's a fourth or fifth stage, and ultimately most of them will result in death. Now, do we have such a classification system that works in pancreas? And actually we do, and there's quite the perfect example, and that's the revised Atlanta classification used for staging of acute pancreatitis, which all of you are very familiar with. It again has these three stages, mild, moderate, and severe, which depend on the presence and length of the presence of organ failure and local or systemic complications. And it's relevant to the patient because we know that there's a good correlation with acute pancreatitis associated mortality. If you have mild acute pancreatitis, according to the revised Atlanta classification, there's virtually no risk of dying from pancreatitis, and this risk increases the more severe disease gets. Moreover, this classification can be used clinically. It helps you to predict course and outcome. It tells you something about the cost of treatment and the length of hospital stays. It can be predicted using other clinical or laboratory markers such as CRP and systemic inflammatory response, etc., etc. And it allows you to allocate resources and guide patient streams by admitting them to ITU, transferring to expert centers, planning the size of expert centers, etc. And it can also be used to cluster patients that have been included in clinical trials to learn about the treatment of those patients. Now, if you look at chronic pancreatitis, it's not quite that easy. And I've taken this cartoon or this schematic from a review on chronic diseases, chronic fibrosing diseases in general, which I came across. And I'm obviously not going to be talking about the translational difficulties, but what are the clinical difficulties that prevent progress and prevent developing meaningful clinical scores? The one is the disease is very slow progressing and it's quite heterogeneous. And the other is that there is a multitude of not very well-defined endpoints, and those are very hard to study. And therefore, the solution for both of these problems in part would be a staging system that allows us to accurately predict outcomes and the disease course also in short to medium term periods, and which will help us to define endpoints that can be studied in larger groups. Obviously, I'm not the first one to talk about this. The idea of staging chronic pancreatitis is actually a quite old idea. And one of the most prominent classification systems that is still in use today is the Cambridge classification, which was developed by a group of experts in 1984. It's based on morphology, initially on pancreatograms and CT scans, but it has been adopted for other modes of imaging, including cross-sectional imaging, endoscopic ultrasound, etc. The problem with this classification, however, is that we've learned over time that morphology does not always follow function. It does not always represent or match up with symptoms, and it has only poor prognostic value. Going on in time, and there have been a number of classification systems suggested in between. About 15 years ago, a large endeavor was undertaken to combine a number of classification efforts into one holistic chronic pancreatitis classification system called the Mannheim classification, named after the city where it was once developed. And many of the people who have been involved at the time are still very prominent with the community today. And the first thing that Mannheim included was the etiology of chronic pancreatitis, using something that has previously been included in the so-called Tiger-O classification published in the early 2000s, and giving a systematic approach to understanding the etiology of chronic pancreatitis in an individual patient. The next step was defining common diagnostic criteria, which are to a large extent based on the before mentioned Cambridge classification, and also included features for endoscopic ultrasound, which can also be found in the Rosamond classification, which has been published in 2009, so 2 years after Mannheim. And then the second to last part of the Mannheim classification were the so-called Mannheim stages, and where patients with chronic pancreatitis were assigned certain stages depending on whether or not they had symptoms and whether or not organ dysfunction was present. And this is something that has previously been suggested, but never really put to practice much in the Manchester and ABC classifications. Now, as you will agree, all of those items included in the Mannheim classification so far are rather descriptive. And the problem is that most of these features are not dynamic. So you can assign them and you can classify your patient, but it's never really been shown whether or not there is a benefit to using the classification system as a whole, or just looking at all these single items. What it does, though, is it puts your patient on a certain spot on the proposed disease continuum from early to late stage, as you will find it in the natural course of the disease. To overcome this problem, another level was added to the Mannheim classification, which is called the severity score and index. And here the authors suggested to assigning certain point values to all those above mentioned features and also added a number of new ones, which was pain, need for interventions, and distant organ dysfunction. And the idea was the more points you collect, the more severe the disease is. The good thing is this gives you kind of an ordinal scale, so you can compare different groups or singular patients between high and low point counts, but it's very complex to calculate. And the other thing is that there's, to my knowledge, so far no study that's really been shown that the severity score index in its original form can really help to guide treatment, as it has not been correlated to a hard clinical endpoint. So what I'm trying to say is that we're not quite sure yet what the number really tells us and what it is a surrogate of. And this brings me to a fundamental problem in the way many of us have been looking at staging diseases and how we've been developing these classification systems. And I borrowed this chart from an American resource used by the FDA to guide the development of biomarkers. And as many of you probably know, is that it's always a multi-stage process in which you discover or develop a biomarker, and then it has to undergo analytical validation and also a step called qualification, in which you basically look whether it's useful in a daily routine before or in parallel to undergoing utilization. And with the previously discussed classification systems, the problem is we've discovered or developed them based mostly on expert consensus, and we started using them, but we've never really validated any of these classification systems in a standardized prospective way with hard endpoints. And therefore, we're unsure whether or not they're useful in clinical practice. Being aware of this problem, our own group, and I've been part of this endeavor for the last 8 years or so, went a different way, trying to prospectively develop a prognosis score for chronic pancreatitis, which might add some value to the aforementioned problems. Here again, we wanted to develop a tool that gives us an ordinal scale, so a number-based score, and we use the Child-Pugh score for liver cirrhosis as a model that is able to objectively measure disease severity and has to be easily to be obtained and can be measured repeatedly, also in an outpatient setting. It had to be correlated to hard endpoints that had something to do with the short to medium term outcome of a patient with chronic pancreatitis, and therefore we choose hospitalization as our endpoint. So therefore the chronic pancreatitis prognosis score, in other words, is basically a point-based scoring system that predicts the risk of hospitalization in chronic pancreatitis patients. It was developed prospectively in a group of 91 patients in 2011 to 2014, and we came up after evaluating about 20 parameters with 5, in our eyes, relevant and more importantly, well-correlated parameters with the primary endpoint, which were the intensity of pain, HbA1c, CRP, BMI, and platelet count. And then again, points were allocated 1, 2, 3, depending on the deviation from normal. And then these points were summed up 5 to 15, and you can make 3 groups, which again is uncomplicated, medium severe, and very severe. And these groups correlate to the risk of hospital admission. And then this chronic pancreatitis prognosis score, short COPS, underwent validation. And that meant it was internally validated, so that's statistics with bootstrapping and then 1,000 repeats. It underwent retrospective external validation in a retrospective cohort of 129 patients. All of these data are included in the first publication. And then we arrived last year at a point where we were able to finish a prospective external validation study. Actually 2 studies, one conducted by our own group with 15 expert centers from around the world, and another one that was completely independent of any of our initiatives from India. And they all showed the same thing, that the COPS is very well correlated with the risk of hospital admission. And this is not only statistically significant, but also, I think, medically relevant. If you look at the individual patient data or individual patient risks, you will find that in COPS-A, the risk of being admitted is only about 25%, whereas it goes up to almost 60% in the COPS-C group. And the same is true for the length of hospitalization. So in the COPS-A group, only very few patients stayed in hospital for longer than 3 days in 12 months, whereas this number went up quite significantly in the higher COPS group. So therefore, if we go back to our chart, with COPS, we are in a different situation. We've, again, completed discovery and development. We have now validated it analytically. And the next point, obviously, to be answered is that we have to prove its usefulness. And this can only be done in use case scenarios. So what are those use case scenarios? One could be, is a scoring tool like this useful in identifying patients for expert referrals? Can it help to guide treatment and evaluate the treatment afterwards? And could it be a surrogate endpoint in clinical trials? And we've only just started looking into all those things, but one initiative that I'd like to share with you, because I think it's very promising, is that COPS is now undergoing evaluation as part of the so-called ESCOPA study, which is a Dutch study, which is prospectively looking in the practice and outcome of endoscopic treatment of chronic pancreatitis in Europe. And these are recruitment numbers from May, and we'll be recruiting patients all through the end of this fall. And COPS will be part of the initial evaluation and will be measured repeatedly during the course of those patients. Now, I'm coming to an end of my presentation. I actually quite confident that we have, with Mannheim and COPS and the morphology-based classification system, quite a number of good tools at hand. But I think the next step will be that we have to learn how to apply them in clinical practice in a meaningful way. With that, I'd like to thank you for all your attention, and I'm happy to answer any questions.
Thank you, George, for a very interesting report. And you have 2 questions. How much of COPS dynamics can a high score go down to low, like a decompensated cirrhosis, could get better?
Well, thanks. That's a really good question. And I think in theory it does. I mean, all those parameters that are included in COPS are dynamic in themselves and technically treatable. We can treat inflammation, we can treat nutrition, we can treat pain, we can treat glycemic control, and so on and so on. What we haven't done yet is doing interventional studies. As I pointed out, we're just at the beginning. So the next thing to be shown is really that after an intervention that brings down COPS, also the risk of further hospitalizations goes down. And I hope that ESCOPA and other studies will answer that question.
And the second questions from Esbjørn Mordreves. I wondered whether all the scales only reflect end stage or close to disease, where it's too late with intervention, referring to our pain discussion before. Is there a chance to establish a future classification system for early disease based on biomarkers such as nicely outlined by Epti Minotti?
It's a wonderful question. Thank you. I think the problem is that early stages of chronic pancreatitis and how to diagnose it is virtually impossible at the moment. At least there is no consensus in the community on what makes early chronic pancreatitis. So I think the only way going forward in this is doing prospective studies where you take patients at risk. And I think the Japanese society has and quite interesting proposal for what this cohort could look like, and then follow them up and do both, clinical characterizations and biomarker studies. Our own group has done some work on metabolomic signatures. So you're not just looking at one biomarker versus another, but you look at groups and build models. So I think there's some promise in that approach. And with regard to COPS, obviously it was the inclusion criteria were based on the current definitions of chronic pancreatitis. So this very early group is probably underrepresented.
And next question is COPS applicable for all countries, considering that criteria for hospitalization in some countries are quite different?
Short answer is yes. So in our, it has yet to be published, but in this larger validation study we did, we had 15 centers from all around the world, including roughly 420 patients. And we did a lot of statistics and basically also repeats with random subgroups. And we didn't really see any changes in the predicted strength. So that indicates that irregardless of where you come from or where those patients were recruited, the score works.
Yes, thank you. Thank you for a very interesting report and discussion. And the next report was pancreatitis, diabetes mellitus, a high volume tertiary center experience. Anna Dugic.
Very good afternoon, and thank you for the opportunity to present our data on post-pancreatitis diabetes mellitus. My name is Anna Dugic. I'm resident in gastroenterology at Bayreuth University Hospital in Germany, and I'm also a PhD student at Karolinska Institute in Sweden. I do not have any financial disclosures. Diabetes is a relatively common complication of pancreatitis, and diabetes occurring during chronic pancreatitis is traditionally classified as diabetes type 3C by WHO and American Diabetes Association. It was not until 2017 that the term diabetes of the exocrine pancreas was coined, and it has been used increasingly since then. Diabetes of exocrine pancreas is the second most common cause of diabetes in adults, surpassing type 1 diabetes. However, type 2 diabetes is by far the most common diabetes type in adults. The most common features of diabetes of exocrine pancreas are pancreatitis with the term post-pancreatitis diabetes mellitus, followed by diabetes in pancreatic cancer and diabetes in cystic fibrosis. Interestingly, more than 80% of cases of post-pancreatitis diabetes mellitus are due to acute pancreatitis bout, whereas approximately 20% are due to chronic pancreatitis. Post-pancreatitis diabetes should be suspected in all individuals with a history of pancreatitis who fulfill the ADA diagnostic criteria for diabetes. To date, there are no standardized diagnostic criteria for this type of diabetes. There are, however, criteria proposed by Ewald and Hart that might be helpful in establishing diagnosis, but the most of proposed diagnostic tests are not feasible in everyday clinical practice. So in this study, we used a recently introduced temporal concept by Petro from New Zealand that seems to be easier to use in daily clinical routine. According to this concept, there are definitions of diabetes types that are mutually exclusive, and PPDM is defined as diabetes that occurs after at least 3 months following the first diagnosis of pancreatitis. Patients have to have normal glucose homeostasis at baseline, which is either first diagnosis of acute pancreatitis or chronic pancreatitis. And this normal glucose homeostasis needs to be evidenced by either normal hemoglobin A1C level or normal fasting plasma glucose. In equivocal situations, oral glucose tolerance tests can be also used. Type 2 diabetes is diabetes diagnosed prior to or within the first 3 months after the first pancreatitis diagnosis. And this 3 months threshold has been taken because hemoglobin A1C reflects average plasma glucose levels over the last 8 to 12 weeks. Type 1 diabetes have patients with positive markers of autoimmunity, and there is also a stress hyperglycemia, which is transient phenomenon with spontaneous resolution after 12 weeks, and it's often seen in acute pancreatitis bouts. Patients with PPDM are frequently misclassified as having type 2 diabetes. These patients with PPDM have worse glycemic control, as PPDM is most commonly also referred to as brittle diabetes, and they also have greater insulin requirements comparing to patients with type 2 diabetes. Accordingly, acute complications are more commonly seen in these patients, and these are severe hypoglycemia and diabetic ketoacidosis. But chronic complications of diabetes, such as microvascular complications in terms of neuropathy, nephropathy, and retinopathy, are as common as in typical diabetes. However, due to scarcity of clinical evidence limited by small sample size of the studies and heterogeneous comparison groups, the actual rates of complications in PPDM remained unknown. So the goal of our study was to assess incidence, risk factors, and complications of PPDM, as well as antidiabetic therapy requirement in a well-defined patient cohort. We retrospectively reviewed prospectively collected data of patients with chronic pancreatitis who presented at our Department of Upper Abdominal Diseases at Karolinska University Hospital between January 1999 and December 2020. The definite diagnosis of chronic pancreatitis was made according to Mannheim criteria. After application of exclusion criteria, we finally included 481 patients in the analysis, and we established 3 different groups that are mutually exclusive. So the first group were patients who were diagnosed with chronic pancreatitis and never with diabetes. The second group were patients with PPDM, and the third group were patients with type 2 diabetes and chronic pancreatitis. And after establishing of these groups, we performed 2 analyses. In the first analysis, we estimated incidence and risk factors for PPDM. And in this analysis, we included 2 groups, patients with chronic pancreatitis and no diabetes, and patients with PPDM. And the date of chronic pancreatitis diagnosis was start of follow-up here. Additionally, we performed second analysis where we compared patients with PPDM and patients with type 2 diabetes and chronic pancreatitis, and we assessed complications and the use of antidiabetic therapy. And we reset the start of follow-up to date of the first diabetes diagnosis. These are our data. They indicate that patients with PPDM, in comparison to patients with chronic pancreatitis alone, had male predominance, more frequent alcoholic etiology, and more frequent history of acute pancreatitis. And after accounting for that as a competing risk, we used competing risk function, and we calculated the cumulative incidence for PPDM of 5.1% at 5 years, 13.2% at 10 years, and around 40% in 20 years after diagnosis of chronic pancreatitis. We also performed cause-specific Cox proportional hazard models where we have done multivariable analysis adjusting for several clinically relevant variables. And we found that pancreatic classifications were independent predictor of PPDM with adjusted hazard ratio of 2.45. The second analysis included patients with PPDM and patients with chronic pancreatitis and type 2 diabetes mellitus. When comparing these 2 groups, we found that patients with PPDM had increase in rate of microvascular complications. This was a composite outcome consisted of nephropathy, neuropathy, retinopathy, and diabetic foot, with adjusted hazard ratio of 1.6. We also found increase in infection rate in patients with PPDM, and the rate of insulin use was 3-fold higher, whereas metformin use rate was 2-fold higher in patients with PPDM. Interestingly, hypoglycemia had also higher rate in patients with PPDM, but this was not statistically significant. We computed these statistics using fine and gray sub-distribution regression models. In conclusion, at the time of diagnosis, about 23% of patients with chronic pancreatitis had type 2 diabetes. A further 13% developed PPDM after 10 years of follow-up. pancreatic calcifications are a predictive marker of future PPDM, and we found that patients with PPDM had higher frequency of complications and were more commonly prescribed insulin and metformin, suggesting a more aggressive phenotype. So taken together, these findings underpin the urgent need for improved and evidence-based management strategies for post-pancreatitis diabetes mellitus. Thank you.
Yeah, thank you, Anna, for your great report. Very interesting. And you have a question. Pancreatitis is one known risk factor for pancreatic cancer. Diabetes is often a first symptom of pancreatic cancer. Are patients who develop diabetes after pancreatic more likely to have underlying pancreatic cancer?
Thank you very much for the question. Well, the short answer is, of course, yes. Pancreatitis is, of course, patients with chronic pancreatitis are at increased risk for developing pancreatic cancer, around 4 to 12-fold than in normal population. But then also new onset diabetes is one of the risk factors for pancreatic cancer, and altogether, of course, the patients are at increased risk for developing cancer. With this study, we wanted to point out and to describe this subset of patients who have chronic pancreatitis and type 3C. It was called like this, and now it's PPDM according to new nomenclature, diabetes. So they are not only at increased risk to develop cancer, but as you can see from our study, they are also at increased risk to have more prominent microvascular complications. And also, according to recently published study from Denmark, it's a observational registry-based study. The patients really exhibited more higher frequency of hypoglycemia and acute diabetic complications. So taken all together, this is a more aggressive phenotype, and with this we would actually like to raise awareness among primary care physicians and physicians of other specialties who do see these patients to ask new onset diabetic about previous history of pancreatic disease and to have a high index of suspicious in such cases.
Thank you. Second questions. Patients diagnosed with type 2 diabetes mellitus, when first diagnosed with chronic pancreatitis, may in fact have post-pancreatitis diabetes mellitus, just because it's at the time of chronic pancreatitis diagnosis doesn't mean it's necessary type 2 diabetes mellitus.
Yes, I agree. That's why we would like to, this new definition which proposed, I mean, I cannot say we proposed it, this is already in use for registry-based studies. This is the first time we used it for real life setting. And this is why we want to test it prospectively. So we would like to actually do glucose homeostasis status in every patient who present with either acute or chronic pancreatitis at our institution, and to see if they were naive. I mean, if they had like normal homeostasis, we would like to check after the first diagnosis over the course of the disease, because of course in equivocal situations, if the patients had been pre-diabetic, they could have pancreatitis that would then trigger diabetes, and we would like to test that at the first visit and then also to on the follow-up subsequent visit to see whether this definition could be applicable, because according to this, there is a clear mutual exclusion of diabetes type 2 and diabetes post-pancreatitis diabetes.
Thank you, Anna. And next report, Clara Ortega Casares, pancreatic exocrine insufficiency, diabetes mellitus and malnutrition in chronic pancreatitis, data from Basque Navarrese Registry of Chronic Pancreatitis. Please, Clara.
Good morning. My name is Clara Hurtado Casares. I graduated in medicine by the University of the Basque Country, and I currently work in the gastroenterology and hepatology unit of Araba University Hospital, which is a tertiary hospital in northern Spain, and I do not have any relevant financial relationship to disclose. The title of the study I'm presenting today is Pancreatic Exocrine Insufficiency, Diabetes and Malnutrition in Chronic Pancreatitis, data from the Basque Navarrese Registry of Chronic Pancreatitis. As you can see, there is a long list of authors, as it is a multi-center study. The aim of our study was to assess the prevalence of PEI, diabetes and malnutrition in a group of patients diagnosed with chronic pancreatitis, as well as to evaluate the factors associated with its complications and how they relate between them. To do so, we conducted an observational multi-center study where we included patients diagnosed with chronic pancreatitis aged over 18. I put a little map to locate us. We work in 2 different regions in northern Spain, the Basque Country and Navarre. As you can see, there are 7 centers that participated in this work. We got a total of 312 patients with a mean age of 61.5 years and with a clear male predominance, with up to 77.2% of patients being men. And if we look at etiology, according to Taigaro classification, there is a majority, 75% of patients suffering from a toxic metabolic chronic pancreatitis, followed by really equally recurrent pancreatitis and idiopathic pancreatitis. And there was a minority of patients with autoimmune, genetic, or obstructive pancreatitis. We are going to start by looking at results about PEI. There was a majority. I'm sorry, you cannot see this well in the presentation, but there were 2,025 patients diagnosed with PEI. And the pancreatic function test that was mostly used was fecal elastase. These patients took a median dose of enzyme supplementations of 150,000 units per day. When we look at how different factors of chronic pancreatitis influenced PEI, we can see that there was a positive association between toxic metabolic etiology and the presence of calcification. However, we did not find an association between the number of endoscopic criteria and the presence of PEI. If we think of how the disease develops, we found something that is logical, as we saw that those patients that had a longer CP evolution time had more presence of PEI. It was 7.6 years for those patients diagnosed with PEI versus 4.4 years for those who did not. And not only did we find that there was a positive association between the toxic metabolic etiology and the presence of PEI, but we also saw that those patients who were active smokers developed PEI earlier than those who had quit smoking. It was 3.9 years for active smokers versus 7 years for former smokers. If we now look on the results about diabetes, we see that this chart is much more equalized, as there's just 50% of people diagnosed with diabetes. When we looked at the type of diabetes that these patients suffered, we can see that there's a majority, 83 patients diagnosed with type diabetes, followed by type 2 diabetes, and were just 6 patients were diagnosed with type 1 diabetes. Logically, again, if we think of patients who suffer from an exocrine pancreatitis insufficiency, we see that those patients also develop an endocrine insufficiency. So patients with PEI were at greater risk of developing diabetes. As well as in the chart we saw before, there was a positive association between patients, between the toxic metabolic etiology and the presence of calcifications. However, unlike the chart before, we did not see a positive association between a longer evolution time of chronic pancreatitis and the presence of diabetes. And the last topic we are going to discuss is malnutrition. If we stick to the European Metabolism and Nutrition Society's criteria according to anthropometric measures, there are only 7.4 patients that follow all these criteria. So there are not many patients. But if we look beyond those anthropometric measures, we will see that there are more patients who may suffer from malnutrition. In fact, when we looked at anthropometric measures, there was something that really struck me. It was that if we look at the BMI, the body mass index, we have a high prevalence of patients who are overweight, even 49.4%. It's almost half of the patients, and up to 16% of patients who have obesity. So it is clear that when we look for malnutrition in our consultation, we have to look beyond their body mass index. However, when we looked at their blood analysis and checked for protein, fat-soluble vitamins or mineral deficiencies, there were 58.1% who had at least one of these deficiencies, being the vitamin deficiency the most prevalent, even if we know it is a very prevalent deficiency in society in general. We also saw that patients with PEI were at greater risk of malnutrition. So, as conclusions, we found that PEI was present in 62% of patients, and it was associated with a longer evolution time of chronic pancreatitis. That apart from being related to a toxic metabolic etiology, its onset was earlier in active smokers. That patients with PEI were at greater risk of diabetes and nutritional deficiencies, and we found a high prevalence of patients who were overweight or obese. And just remind that the assessment of malnutrition has to go beyond anthropometric measures. So thank you very much for your time and your attention.
Thank you, Clara, for your very great report. And next report, the final report in our session, Andrea Pamitsky, genetic factor behind the recurrence of pediatric pancreatitis, result from APPLE-R, analysis of pediatric pancreatitis, prospective, multicenter, observational clinical study.
Thank you. Can you hear me, and can you see my slides?
Yes, go ahead.
Okay.
Yes.
So, dear colleague, I would like to extend my thanks to the Scientific Committee of EPC for giving me the opportunity to present a part of our results from APPLE study. Since the discovery of the first trypsinogen mutation in families with hereditary pancreatitis by David Whitcomb back in the 90s, the field of pancreatic genetics has made rapid progression. At the same time, pediatric pancreatitis has also come under the spotlight, not only because of the gradually increasing incidence, but also because of the childhood onset of the disease. And after all, we all know that the earlier in life a disease starts, the more likely genetic factors play a role in its development and progression. Almost 1/3 of acute pediatric pancreatitis cases remain idiopathic after the routine etiological workup, which reinforces the hypothesis that there are several hidden factors in the backgrounds, such as genetics. A recent meta-analysis found that in 16% of pediatric pancreatitis has a confirmed genetic background. The true prevalence of predisposing genetic alterations is likely considerably higher, since most included studies did not stick to a rigorous genetic testing regime. Thanks to the remarkable scientific effort and the growing body of the literature, more and more information becoming available, but there are still many questions needs to be answered. Here you can see the current available European pediatric pancreatitis guidelines recommendation regarding the genetic testing. It says that in patient with second episode of idiopathic AP or a first episode of idiopathic AP and a family history of AP, a full sequence analysis is recommended. But why these genes? And the majority of pancreatitis risk genes code for digestive proteases, a trypsin inhibitor, or other proteins highly expressed in the pancreas. The trypsin-dependent pathological pathway variants in susceptibility genes PRSS1 encoding cationic trypsinogen, the SPINK1 encoding serine protease inhibitor casal type 1, and CTRC encoding trypsinogen C increase pancreatitis risk by promoting harmful trypsinogen activation and by impairing protective trypsinogen degradation and or trypsin inhibition. Aberrant expression of CFTR leads to a diminished fluid and bicarbonate secretion to the duct. This leads to decreased intraluminal pH and decreased washout of digestive enzymes and more viscous protein-rich ductal fluid. These changes promote the formation of intraluminal protein gel or plugs, which are early histological features of chronic pancreatitis. Mutation-induced misfolding and consequence endoplasmatic reticulum stress leads to acinar cell damage and pancreatitis. The best characterized misfolding variants are the PRSS1 and carboxypeptidase A1 are strong causative risk for chronic pancreatitis. To answer the above-mentioned question in the introduction, the Hungarian Pancreatic Study Group launched an international multi-center observational study to better understand pediatric pancreatitis. This is the APPLE, or Analysis of Pediatric Pancreatitis Study. This study has a retrospective and a prospective part. In the retrospective part, we identified those individuals who had either a single episode of acute pancreatitis, multiple episodes, so acute recurrent pancreatitis or chronic pancreatitis when they were children, and approached them for participation. We fill out a brief questionnaire in which we assess the progression of the disease, so how many pancreatitis episodes they had, whether they developed chronic pancreatitis or not, and the etiology. We collected blood samples to analyze known pancreatitis risk increasing genetic variants. So from the collected information, we will be able to evaluate the association between these mutations and the disease progression and other etiological factors. The study also has a prospective part where we mostly focusing on the clinical course of pediatric pancreatitis, collecting robust clinical laboratory and imaging data with the primary goal of establishing an unadmission severity predicting score system. But here we also collect blood samples for genetic analysis. So with this bunch of data, we can draw association between genetic alteration and disease severity. In my presentation today, I will present the preliminary results of APPLE-R part. Until now, we enrolled 166 participants who had a single episode of pancreatitis when they were children, 68 who had multiple, and 29 who developed chronic pancreatitis. Quite understandably, chronic pancreatitis patients were older at the time of enrollment and younger at the onset of the disease, ergo the first pancreatitis episode, since the disease progression requires time. Those who had a single episode were not only older at the time of disease onset, but, and this is an important limitation of our study, their follow-up period, the time that passed between disease onset and enrollment, was also significantly shorter. This means that there can be cases misclassified as AP that can still develop acute recurrent and chronic pancreatitis until they reach adulthood. When all participants they reach adulthood, so we can conduct a secondary analysis at that time point. Significantly more acute recurrent and chronic pancreatitis patients had a positive family history than those with a single episode. This mostly means acute and chronic pancreatitis, but it should also be pointed out that 14% of chronic pancreatitis patients had pancreatic cancer in their family history. And acute recurrent and chronic pancreatitis patients were more likely maintain any kind of diet. Regarding etiological factors, or more appropriately risk factors for pancreatitis, among those who with a single episode, biliary obstruction was the leading cause, followed by confirmed risk increasing genetic alteration in about 30% of cases, then systemic causes, and so on. Among those with multiple episodes, genetic risk factor rose to 50%, increasing to 55% in chronic pancreatitis patients. The genetic analysis is not yet complete. From 261 patients, enrolled patient genetic analysis is complete in more than 200 cases. In the remaining 57, the genetic analysis is incomplete or not yet analyzed. From the tested group, almost half of them have at least one pathogenic mutation. On this figure, you can see the breakdown of identified risk increasing mutation according to the affected genes. The side of the circles corresponds to the number of individuals. So, for example, 10 participants had SPINK1 mutation only, and 11 have transheterogeneity according to SPINK and CDRC. Here you can see the distribution of these genes alteration according to the disease progression. And we found a significant intergroup difference with PRSS1 and SPINK1. You can see the prevalence of these mutations increasing from AP to ARP and from ARP to CP. We also note a similar tendency, although without statistically significant difference in cases with CDRC. It should be also noted that having more risk increasing mutation was significantly more common among chronic pancreatitis patients. We also calculated the cumulative risk based on the documented CP risk of pathogenic variants. And you can see here that it's increasing through the groups, and based on this cumulative risk, hopefully in the future we can predict the disease onset and the progression of the disease. So to conclude, do not forget positive family history of pancreatic diseases in children, which occur more often with children in acute recurrent and chronic pancreatitis. And in the future, maybe these patients who have positive family history need a closer follow-up for follow the disease progression. And regardless of the etiology, more than half of the children with pancreatitis have genetic predisposing factors. So the question is still there, that are there history for chronic pancreatitis is written in the genes? A follow-up study are needed, so we created the follow-up part of the Apple trial, and we also want to catch up both the exocrine insufficiency, to the progress of the exocrine insufficiency, and the endocrine part as well. So hopefully in the near future we can provide data about this as well. I would like to thank to my colleagues who are helping me running the Apple trial, and also for the Hungarian international collaborators for sending us clinical data and biological material, and for you for your attention.
Andrea, thank you. Very interesting report. Dear participants, we are completing our session. We heard 7 reports devoted to the pathogenetic, diagnostic and treatment of chronic pancreatitis. And I want to thank all speakers for very interesting, great report for actual problem of different questions of chronic pancreatitis. And see you later.
And please join the General Assembly at 6:30. Thank you.